Okay, let's start from here. Assalamu alaikum, everyone. Welcome back to another PAL. My name is Leen Alfadhel. I'm a second year medical student, and along with
Hi guys, my name is Humaira Khalidi and I'm also a second year medical student.
together, we'll be covering the anatomy of the lower GI and the anterior abdominal wall. So, let's get started. This is what our roadmap looks like today. I'll be covering pancreas, small intestine, and the large intestine and the rectum, and Humaira will take care of the rest, inshallah. So, let's start. First of all, with the pancreas. Well, the pancreas is an endocrine organ that secretes hormones into the blood. So that's the meaning of endocrine, right? It's also an exocrine organ. It's exocrine because it secretes substances like HCO3 and other digestive enzymes into ducts using these ducts right here, like the bile duct or the pancreatic duct. And it lies in the epigastric, umbilical, and left hypochondriac regions at the level of L1 to L2 vertebra. So, if we draw right here, I'm pretty sure you guys have taken this. If we draw 9 quadrants, this should have been a bit more up. It lies over here, which is the epigastric. It lies over here, if you can see it, the umbilical region, and it lies at the left hypochondriac region. Okay? All right. Let's go next. Now that we know a bit about the pancreas, let's see where it's actually situated. The pancreas is retroperitoneal. That means that it is behind the peritoneum. It's not covered by the peritoneum, except for the tail. And we'll see why in upcoming slides. It extends from the concavity of the duodenum, so from here, all the way up to the spleen's hilum, and it crosses the transpyloric plane, which is at the L1 vertebral level, and it lies midway between the xiphisternum and the umbilicus. So if you still remember your CVP, here's your sternum somewhere over here, your xiphoid process, and here's the umbilicus. So right midway between the xiphisternum and the umbilicus, you'll find the pancreas. Now, I mentioned lots of words such as transpyloric plane, but do we actually know what that means? Not yet. So let's find out. So the transpyloric plane is basically an imaginary line at the level of L1 vertebra, and it passes through the pylorus of the stomach. It's the tips of the ninth costal cartilages. So here are some ribs. At the tips of the ninth costal cartilage is where you'll find the transpyloric plane, and the lower border of the L1 vertebra. And it includes all of these structures. Now, you do need to know these structures. However, just memorizing them route like that, it's not that easy. So, I prepared for you guys a mnemonic. The mnemonic says, "Hi, hi, let's please put the 9 forbidden drugs on the boat." So, hi, hilum, hi, hepatic portal vein, L for L1 vertebra, P for pylorus, P for pancreatic neck, 9 costal cartilages, F fundus of the gallbladder, D duodenojejunal junction, origin of the SMA, and the beginning of duodenum. So let's translate this to the picture right here, because it's easier to know things if you visualize them. So here's a transpyloric plane. Okay, so high, hilum of the kidneys. Okay, high, the hepatic portal vein, which is right over here. Let's lumbar vertebra, lower border of the lumbar vertebra of L1. Put pancreatic neck. Uh, please put actually, please, which is the pylorus of the stomach. Please put the ninth costal cartilages, forbidden fundus of the gallbladder, drugs, duodenojejunal junction. You can't see it here. However, we'll soon learn about it in the upcoming slides. This is the duodenum, okay, which is a part of the small intestine. So if you continue the duodenum, this is how it continues. Goes just a bit more up, okay? And this flexure right here, we call it the duodenojejunal junction, where the duodenum and the jejunum connect together, okay? Drugs on origin of the superior mesenteric artery. That artery, we're also going to see it in the upcoming slide. And boat, which is beginning of duodenum, okay? So memorize this. Now, now that we know about the pancreas, let's see the parts. So the pancreas has four parts: the head, the neck, the body, and the tail. And coming out of the head in a hook process is the uncinate process. It's a small extension from the head, which just hooks around to the left. And a very important note here, remember when I said that all parts of the pancreas is retroperitoneal except for the tail? Well, it's because the tail passes through the splenorenal ligament or the lienorenal ligament. So, this is a spleen, and here is the tail of the pancreas. The tail is sitting right in in the middle of the splenorenal ligament, which connects the spleen to, I believe, the kidney from the name. Okay? And yeah, it runs between the spleen and the kidney. Now, the head. This is the first part. Okay? The head lies within the concavity of the duodenum. So remember the duodenum, it's a C-shaped small intestine, so it lies within the head of the duodenum. It also um, lies below the transpyloric plane. So remember what was in the transpyloric plane? The neck, the pancreatic neck. And the uncinate process extends to the left, behind the superior mesenteric vessels. I will show you a picture of how that looks like because you will not be able to understand from just this image. And here we are to the relations. Now, guys, as you can see, the background has changed. In my slides, that basically means that I've seen a past question or a question in the red files relating to the slide. So pay attention to these slides. So, relations. The first relation here is anteriorly. What do we find anterior to the head of the pancreas? So, first of all, we see the root of the transverse mesocolon. This is the transverse mesocolon. We see the transverse colon, okay, and that is run anterior to it. And here are the superior mesenteric vessels, which I just talked about. So, this is the uncinate process running like from behind, and then it comes in front of it is the superior mesenteric vein and the superior mesenteric artery. Okay? Posteriorly, you will find the right renal vein, the common bile duct, and the inferior vena cava. Okay? So, guys, with relations, because there are a lot of relations in these three lectures, lots of relations, I need you guys to just draw. So I will not be drawing every relation to save time. However, this is what I like to do in order to learn anatomy. So, your pancreas, okay? Anteriorly, I'll change the color for anterior. Anteriorly, what do I find? I find the root of the mesocolon, I find the mesocolon itself, and I find the superior mesenteric vein and superior mesenteric artery. What is behind it? I will change the color for posteriorly. Posteriorly, I find the right renal vein, I find the common bile duct, and I find the IVC. Now, if I show this image to anyone, it won't make sense for anyone, but it will make sense to me because I drew it. And that's what matters in anatomy. So, next. Between the superior mesenteric artery and aorta, you have some structures. Okay? So, if you zoom in here, this is the aorta, and coming out of here is the superior mesenteric artery. Between them, you have some structures because this is the aorta. This is how the superior mesenteric artery goes. So there's some stuff in between. What do you have? You have the third part of the duodenum. Now, we didn't get into duodenum yet, so I don't expect you to know what this first, second, third part mean. But just to orient yourself, just for now, here's the first part of the duodenum. Here is the second part of the duodenum, and here is the third part of the duodenum. Okay? Just to orient yourself. What do you also find? You also find the left renal vein. So, here's the left renal vein. It's running between the superior mesenteric artery and the aorta. And you can also find the uncinate process. Remember where's the uncinate process? It's right over here. Okay? So these are all the relations in between SMA and aorta. Next. So, we're done with the head. Let's go down to the neck. So the neck is 2 centimeters in length, and it lies mostly behind the pylorus. Pylorus is a part of the stomach. I expect you guys to have probably studied the stomach before going to this lecture. So, Relations. Anteriorly, you find the pylorus and the pyloroduodenal junction. Pylorus, part of the stomach. Pyloro, relating to the pylorus. Duodenal, relating to the duodenum. So, the junction between them. That's what we find anteriorly to the neck of the pancreas. What do we find posteriorly, though? They've taken out the neck from here. So, when they check it, they saw that superior mesenteric vein joins with splenic vein to create the portal vein. And that is what you find behind the neck of the pancreas. Okay, what about the body? So, the body, when you take a cross section, is triangular. I couldn't find any pictures to show you how that looks like, so I would imagine it could look like that probably if I take a cross section. And it runs upwards and left. So the pancreas is not sitting like this. It's kind of sitting like this. Head is down and the tail is up. Um, when talking about relations on the superior border, so running along the superior border is a splenic artery. And on the anterior border, so on not the surface, on the border itself, so somewhere over here, okay, you'll find the transverse mesocolon, this sheath over here. Anteriorly, you'll find the lesser sac, but it's not shown here, and you find the stomach. Posteriorly, you'll find many structures. You find the aorta, the IVC, the splenic vein, and the left kidney, and its vessels. So, the renal vein. Okay. Pancreatic tail is our last part, and it's important. Two facts in this slide I really want you guys to know, like your name. Number one, it lies in the splenorenal ligament. That means it's what? It's intraperitoneal. Number two, it's intraperitoneal. Number three, that it contacts the splenic hilum. It's a very important point. I've seen a question on this. So here's a spleen, contacts the hilum. Okay? All right, so now that we're done with pancreas anatomically, let's discuss the blood supply. Now, there are three vessels here, which is splenic artery, superior pancreatico-duodenal artery, and the inferior pancreatico-duodenal artery. Three blood vessels. However, I want to show you them on this schematic. So, this is aorta, right? Coming out of it is the celiac trunk. Celiac trunk will divide into the common hepatic artery. Coming out of the common hepatic artery is what I want to focus on is the gastroduodenal artery. So the gastroduodenal artery will run posteriorly and superiorly and anteriorly as what? As the superior pancreatico-duodenal artery. Break the word down. Superior is up. Pancreatico relating to the pancreas, duodenal relating to the duodenum. So what does it supply? Supplies the first part of duodenum, probably, and like probably the second part as well. And it supplies the pancreas. Now, those will anastomose with what? They will anastomose with the inferior pancreatico-duodenal artery. But the inferior one does not come out of the gastroduodenal. No, it comes out of the superior mesenteric artery. So just to recap, okay, gastroduodenal artery will split into the superior pancreatico-duodenal artery, anteriorly and posteriorly. Okay, superior mesenteric artery will split into inferior pancreatico-duodenal artery, anteriorly and posteriorly. Those two branches will anastomose to supply the head and the uncinate process of the pancreas. What about the left side? Okay, on the left side we have the splenic artery, which will give you some pancreatic branches. Okay, so that's about the arterial supply. What about the venous drainage? I did mention some veins back then in the relations, and that is exactly the venous drainage of the pancreas. Superior mesenteric vein joins with splenic vein to drain into the portal vein. That's your venous drainage. And lastly, lymphatic drainage. All you need to know is that there are a bunch of nodes over here, but all of these nodes eventually drain into either the celiac lymph nodes, which are right up here, or into the superior mesenteric lymph nodes, which is right over here. Okay? For nerve supply, the sympathetic supply is T5 to T9 splanchnic nerves. Memorize it. And parasympathetic supply is vagus nerve. Okay? Now, Now I will go into ducts. So pancreas, remember I told you is an exocrine gland. It's an endocrine gland, but it's also an exocrine gland. In order to carry out its function of being an exocrine gland and secreting those digestive enzymes and bicarbonate into where? To the duodenum. It needs something to connect it to the duodenum, right? So we have two ducts. The first one is the major pancreatic duct, which is also dubbed as the duct of Wirsung. So you can also call it the duct of Wirsung. It originates from the pancreatic tail. Okay, so it starts off from the pancreatic tail and it goes all the way down. Okay, and it basically joins with the common bile duct. Okay, it will join with the common bile duct to create this entire pathway. So let's see how this looks like. When it joins with the common bile duct, it will create a small canal, right? Now, where will that small canal go? It needs to go somewhere. It goes into the duodenum. Which part of the duodenum? The second part. So remember when I oriented you just a bit? Here's the first part, here's the second part, here's the third part. So, and the second part is where you find it. And that opening, we call it the ampulla of Vater. Okay? The opening is called the ampulla of Vater. Where does it open to? It opens into the major duodenal papilla. So, this is the ampulla of Vater. The hole itself is called the ampulla of Vater. Where does it open to? Into this structure right here called the major duodenal papilla. Okay? Now, now we have a canal, right? Okay. So we have somewhere to dump all the digestive enzymes to. But we need to control the amount of digestive enzymes that we are secreting, right? We cannot just keep on throwing it all onto the duodenum. There has to be some sort of control. And that control comes from it being a sphincter. So some muscles will wrap around the ampulla and it will create a sphincter called the hepatopancreatic sphincter of Oddi. Okay? And that's it. For the second duct, we call it the accessory duct. Now, the accessory duct is also dubbed as the duct of Santorini. So they can get you on the exam, either accessory duct or duct of Santorini. And fun fact, it's not always present. It's okay if you don't have it, but it's also okay if you do have it. And it drains the upper part of the head of the pancreas, okay? And it will open into the second part of the duodenum as well, into the minor papillae. So this is it. This is the major. This is the minor. It's very close, just right above it. And that's it, guys, for pancreas. So here's a question for you. A patient with a history of chronic pancreatitis came to the ER with bleeding. He was rushed to the operating room, and the surgeon repaired the artery responsible for the bleeding. Which of the following arteries is the cause of the bleeding? Give you guys some time to solve. Pause the video if you'd like. All right, so this is the answer. Splenic artery. So, keyword here is chronic pancreatitis. So we're talking about the pancreas. Okay. So the surgeon repaired the artery responsible for the bleeding. So it's basically asking you which of the following arteries supplies the pancreas. Left gastroepiploic does not. That's for the stomach. Short gastric, stomach. Right gastroepiploic, stomach. So what do we have left? Splenic artery. Okay, now we're done with the pancreas. Let's go into the small intestine. Now, the small intestine is divided into three parts. You have the duodenum, which is further divided into four parts, as we talked before. It is 10 inches long and it is retroperitoneal, except the first inch. Okay? And I'll mention that even more further. It also consists of the jejunum and the ileum. So, The first part of the duodenum. The first part of the duodenum is 2 inches long and it lies at the level of L1 and it contains the portal triad, hepatic artery proper, common bile duct, and portal vein. And if you guys have been to the ultrasound lab, I don't know if you have done that lab yet, but we called it the Mickey Mouse, I remember, because it looked like a Mickey Mouse under ultrasound. Now, this is what I was talking about earlier. The first inch is called the ampulla or the duodenal cap, okay? And it lies within the hepatoduodenal ligament, okay? It lies within a ligament. So what does that mean? It's intraperitoneal, okay? Now, the duodenal cap is the most common site of duodenal ulcers. Fun fact. And it's an important fact. Keep this in mind. They could easily give you an MCQ about this. But now let's go into relations, our favorite. So, superiorly, you'll find the epiploic foramen. Now, this is the epiploic foramen is right behind this part. So it's right behind that peritoneum, that piece of peritoneum. And by the way, that is the hepatic duodenal ligament. Fun fact part two. Okay, that's the hepatic duodenal ligament. Okay. Now, inferiorly is the pancreas, which is right over here. Anteriorly, you'll find the quadrate lobe of the liver and the gallbladder. So what they've done here, that they've lifted the liver up. So this is like the duodenum. The liver was like this. They just did this, just to show you how the quadrate lobe looks like. Here's the quadrate lobe, and here is the neck of the pancreas, of the gallbladder, my bad. Posteriorly, you'll find the gastroduodenal artery, which is right over here. Okay. You'll find also this part exactly. Okay. You'll find also the portal vein and the bile duct, and also the IVC. Okay, posterior to the first part. Now we're done with the first part. Let's go to the second part. So the second part is basically this part, the descending one. The descending part. It's 3 inches long. It lies at the level of L2 to L3, and it overlies the hilum of the right kidney, vessels, and ureter. So just imagine with me that there is a right kidney here. So it overlies the hilum of it, and the vessels, which is probably the right renal vein, and the artery, and the ureter. And you'll find something called plica circularis. So those plica circularis is basically what distinguishes the first part from the second part. If I go back, okay. See how the first part, specifically the first inch, is very smooth, okay? And then it gets more rough here and more muscular, okay? Because there's more folds. Those folds are the plica circularis, and I'll show you a picture soon. Now, remember back then when we talked about the ducts, okay? On the posterior medial wall, okay? That is where the ducts will open, posteriorly and medially. Okay, relations. Anteriorly, you'll find the right lobe of the liver and the fundus of the gallbladder. You'll also find the transverse colon and the mesocolon. The mesocolon, I'm pretty sure you guys know how that looks like by now. I hope so. Somewhere over here. And just imagine with me, that's a mesocolon. Okay? So that's where you find anteriorly to the second part. Medially, you'll find the pancreas. So this is the second part. Medial to it, you'll find the pancreas. Now, okay, wait, hold on. I'm gonna pause. Okay, so now we've reached the third part of the duodenum. The third part of the duodenum is 4 inches long, and it runs horizontally, crossing the midline. So there's a midline over here, it just crosses it, and it runs horizontally. Relations, let's go through this pretty quick. The root of mesentery. So there's a mesentery here. This part is called the root of the mesentery, okay? And this entire part, root of mesentery, anterior to it. And superior mesenteric vessels. So the vein and the artery, superior mesenteric vein and artery, runs anterior to the third part of the duodenum. Posteriorly, you'll find the right psoas major muscle and the right ureter and the IVC and the aorta. So just everything's to the right. Psoas, ureter, IVC, aorta. Okay. Superiorly, you'll find the inferior border of the head of the pancreas. So this is the third part, right? So the inferior border of the head of the pancreas runs superior to it. Fourth part is our last part. It's 1 inch long, so it's the shortest part of the duodenum, and it runs obliquely and upwards along the left psoas muscle. So this is the left psoas. It runs along it up obliquely, so in a diagonal way. And it ends about 1 inch to the left of the midline, forming the duodenojejunal flexure. So let's get out the pen. There's like a midline here, kind of. Ends around 1 inch to the left, forming this flexure right here, which is called the duodenojejunal flexure, connecting the duodenum to the next part, which is the jejunum. And this duodenal jejunal flexure has to be supported, right? So what is it supported by? It's supported by peritoneum, but it's also supported by this ligament right here called the ligament of Treitz. Okay? This ligament of Treitz is it connects to this part. Do you guys remember what this part is called? If you remember CVP, this is a diaphragm, and the diaphragm has crusses. So this is the right crus, so it attaches to the right crus. Okay, because if you don't have it, then the thingy just falls. Okay. Relations. So anteriorly, what do you find? Coils of jejunum. So just imagine jejunum over here. You cannot see it. Posteriorly, you find the left margin of the aorta. So this is the aorta. So the left margin of the aorta. The lumbar vertebra, which is all the way, you can barely see it. This is the lumbar vertebra in the back. Now, when you swallow, now there's something called the barium swallow, okay? It's basically like this X-ray imaging method where you basically swallow a liquid which has some contrast. So this is in order to visualize the upper GI tract and the lower GI tract. So when they did a barium swallow over here, this is the stomach, right? In the stomach, we have the pyloric antrum, and then we have the pylorus. When we find the pylorus, what is right next after it? The duodenal first part. Okay? Now, this is what I meant by, this is what I wanted to show you regarding plica circularis. Look at the difference between duodenal first part and duodenal second part. This is smooth, but this is not smooth. This is like aggregated. This is like rough, kind of jagged, right? And this is because of the presence of, you said it, plica circularis. Okay? Over here, stomach, pyloric, same thing. First part, it's kind of smooth. You transition into the second part, it becomes jagged and it becomes very rough, and that means there are plica circularis and yeah. Okay. Now that we're done with duodenum, let's go to jejunum and ileum. So the jejunum and ileum together, they're 20 feet long, 6 centimeters long. Okay. The jejunum consists of the upper 2/5 of the intestines. The ileum considers the lower 3/5. Okay. And the jejunum is more situated to the left, and the ileum is more situated to the right. And they're connected to the posterior abdominal wall by what? By the mesentery. Now, speaking about mesentery, this is how the mesentery looks like. This is when you take out all the jejunum and ileum. And it's 6 inches long, okay? When you measure it just like this, when you don't take out of the intestines. However, let's say you take out the intestine and you stretch it, the intestines are very long, right? You'll find it to be around 6 meters long. So imagine from 15 centimeters to 6 meters long. And when you measure the depth of it in the center, it's 20 centimeters long. Listen, those numbers, honestly, I haven't seen any question on them. There are specific measurements that you do have to know. Um, However, for example, the depth thing, I don't think I've ever remembered seeing a question about that, but just know it just in case. I don't know what they're going to ask you. Anyways, the mesentery runs obliquely at a 45-degree angle, and um, okay, its root crosses the third part of duodenum, the aorta, the IVC, the right psoas, the right ureter, the right gonadal vessels. Lots of things, right? Lots of things. What does that mean? I have a mnemonic for you. So, the mnemonic is, damn, anatomy is painful. Ugh, kind of true, kind of not, kind of like anatomy. So, D for duodenum, third part specifically. A for aorta. I for IVC. P for psoas. U for ureter. And G for gonadal vessels. And fun fact, everything here, the pug here, all to the right. So, right psoas, right ureter, right gonadal vessels. And the mesentery is attached to the posterior abdominal wall. How? First, it originates from the duodenal junction, just from here, the duodenal junction. Okay. And where does it insert? It inserts all the way down to the right sacroiliac joint, the joint between the sacrum and the iliac crest, I believe. I forgot which one, but it's the right sacroiliac joint. Okay. Now, jejunum ileum, kind of like from afar, if you generally don't know the true anatomy of it, kind of look the same. But if you dive deep into it, they're actually pretty different. How are they different? Number one, and by the way, this is very important. This slide extremely important, not only for MCQs or SAQs, but also very important in OSPE. So, first of all, the jejunum is redder in color. Why? Because it has more plica circularis. And those plica circularis are larger and they're more closely set and they give it that red color compared to the ileum. The jejunum is also more thick-walled, as you can see here, compared to the ileum. It has a wider lumen, even though it doesn't look like it, but it does have a wider lumen than the ileum. And when it comes to fat, this is a very important thing to consider. I've seen questions on this and very important, very important. This is the fat, right? As you can see, the fat does not reach to the intestinal border. It doesn't reach to the intestinal border. Compared to the ileum, the fat reaches all the way to the intestinal border. Okay? So go to the lab. If you haven't done this already, go to the lab. Um, lift up, lift up like the jejunum, طيب, with the its mesentery or whatever, and then put your hand behind it, okay? And then put it like at the intestinal border. You can see through it and you can see your hand. You do the same thing to the ileum. You will not be able to see your hand as clearly because of the presence of fat. Okay? So that's like a fun little experiment you can try. Now, also, arterial arcades are very different here. Jejunum, they're way less. You have 1 to 2 arcades, okay? Yeah, you have 1 to 2 arcades. Versus the ileum, you have more than 3 arcades, okay? And what else? There's also, they're also very short in the ileum, and in the jejunum, they're very long. So as you can see, they're very long here, but compared to the ileum, it's very short, okay? And histologically, you'll find Peyer's patches in the ileum. You'll find patches in the ileum, but you will not find it in the jejunum. Okay? And yeah, this is everything else that we've talked about. It also has a complete, they both have complete muscular coat. That means they have an outer longitudinal and an inner circular fibers. So, um, outer longitudinal, so the fibers are going longitudinally. I don't know why my pen is not working. And inner circular means the fibers are going circularly. Hope you can understand that. Okay. Um, what about the barium swallow? Okay. They do a barium swallow test. As you can see, the jejunum here is way more rough, way more jagged. You know, what does that mean? Plica circularis. There's a lot more plica circularis in the jejunum than in ileum. Ileum looks very smooth in compared to the jejunum. Perfect. We're done with the small intestine anatomy. So now let's talk about the arterial supply. Now, there's a lot to uncover, okay? Common hepatic artery has a lot of divisions. However, I will explain to you on this diagram. So, this is your abdominal aorta. Coming out of the abdominal aorta, you have the celiac trunk. The celiac trunk has three different divisions, right? However, I will not get into the left side. We will focus mostly on the right side. Common hepatic artery comes out of the celiac trunk, okay? And it will split into the hepatic artery proper and into the right gastric artery. And then it will further split into the right hepatic artery and the left hepatic artery. And it will give one little artery coming out of the right hepatic called the cystic artery, which supplies the gallbladder. Right hepatic, left hepatic proper, they supply what? They supply liver. Right gastric artery will anastomose with the left gastric to supply the stomach. As you can see, there's no alaqa at all to the intestines nor the pancreas, so why are we talking about it? Well, it was in your lecture, so we have to cover it. However, there is one artery here that I have not spoken yet, and I'm concerned with it in regards to our lecture today, and that is the gastroduodenal artery. The gastroduodenal artery comes out of the common hepatic artery, okay, and splits into the right gastroepiploic artery. Right gastroepiploic will supply the stomach, and it will continue down as the superior pancreatico-duodenal artery, and just what we uncovered before, remember, on the relations part. That's everything that we just said, okay? Superior mesenteric artery. Here's a superior mesenteric artery. We've been talking about it nonstop. Superior mesenteric artery comes out of the aorta. Okay. The very, very, very first branch coming out of the superior mesenteric artery is the inferior pancreatico-duodenal artery. I'm very sure that we got this a question back then. I'm very sure. Because I remember seeing that question and I got it wrong. Okay, but this is the first artery that comes out of it. And then it continues down and gives you jejunal branches, ileal branches, and more arteries over here, which I will cover in a bit. So, we're done with all the macroscopic things. We're done with all how the small intestine looks like, how the pancreas looks like, everything. But I want to take a step back and visit some embryological concepts in order for you to understand what's coming next. So, you have something here called the yolk sac, right? Yolk sac provides for nutrition. And you have something here called the primitive gut. What connects the yolk sac to the primitive gut is this duct right here that we call the vitello-intestinal duct. This vitello-intestinal duct appears in the fourth week, okay, of embryonic development. And it usually disappears by seventh week. It should disappear by the seventh week. Okay? This is the gut side. On the bladder side, you have the allantois, which is right over here, which will turn into the urachus, and then it will eventually obliterate as the median umbilical ligament once the baby is born, and that will eventually connect to the bladder. I'm not concerned with this for this lecture. This is probably in embryology, I'm pretty sure, but I am concerned with this. Why am I concerned with this? I'm concerned with this because of the upcoming clinical cases. So, our first clinical case is Meckel's diverticulum. So its etiology, which means its pathogenesis, is that the vitello-intestinal duct is remnant. It did not disappear by the seventh week. So what happened to it? It will become like an outpouch of the terminal ileum. Okay? In Meckel's diverticulum in specific, it will become a diverticulum right over here. So it's like a full pouch. However, it can go through different anomalies, like it can be a cyst, or a fibrous band, or a polyp, or a fistula, okay, or a diverticulum, like in Meckel's diverticulum. Now, there's a really nice mnemonic that you need to know for Meckel's diverticulum, and that is the rule of twos. So, it's found in 2% of the population. It is 2 feet away from the ileocecal junction, okay? The ileocecal junction, I will show it to you in a bit. It is 2 inches long, okay? And it is 2 times more common in males. It is it has 2 types of ectopic tissue, gastric and pancreatic. So ectopic means that it's tissue that is not supposed to be there because you need to have intestinal tissue right here, right? But for some reason, gastric and pancreatic tissue was present there. And is 2% present with complications like diverticulum, disappearance, bleeding, all of that. Okay? Now, I highlighted this one because I want you to focus on this sentence right here. 60 centimeters proximal to the ileocecal valve. Saw this in the red files. So just know it. Our next pathology is diverticular disease. Now, diverticular disease, okay, can either be diverticulosis or diverticulitis. Osis means condition, okay? So it's a condition of the diverticulum. Itis means inflammation. So it's when it's inflamed. So osis is basically the outpouching of mucosa and submucosa through weak spots in the muscular layer. So how does that look like? It basically means that you have these diverticula coming out or they're forming in the wall of the colon. Now, I'm pretty sure this is all right. This is like benign. Okay, it is a risk factor, but it is benign. It's okay. But when does it become a problem? It becomes a problem when a rupture or when an artery is ruptured or obstructed in this area, and that will cause bleeding, and that can lead to inflammation, and it can also lead to infection. So, diverticulitis is inflamed or infected diverticulum due to rupture or obstruction of the arteries that are present here. How does that look like on barium swallow or an X-ray? This is transverse colon, and this is ascending colon, and right over here is the cecum. Okay, ileocecal valve is somewhere over here. So we're in the cecum, and here's the ileum. Okay, so that means if you just trace around, this is the ileum. Coming out of the ileum are these like spots right here, or like these outpouchings, which are the diverticula. Okay, so that's it for small intestine. So let's lock in. Where is Meckel's diverticulum located? Give you a few seconds to answer this. Could pause the video if you'd like. B. 60 centimeters proximal to the ileocecal valve. We finally reached our last objective on my part, and it is the large intestine. Now, the large intestine is 6 feet long. It's 2 meters long, okay? And it has a bunch of features. It has something called epiploic appendages, which is right here. Those are basically fat-filled outpouchings that are present on the large intestine. You also have something called the tinea coli, which are basically 3 incomplete longitudinal bands of muscularis externa. So it's just 3 bands of muscles running along the large intestine, and it will create like you need the muscles there, you know. Where's the tinea? Yeah, here's the muscles. Tinea coli, okay? And bands of muscularis externa. Underline 10 times on muscularis externa. Seen that in the red files. And the hostra, okay, hostra is basically these pouch-like segments. This is a hostra, here's a hostra, here's another one, here's another one, here's another one. And they're formed because the tinea coli are shorter than the colon themselves. So when something is like shorter than the colon themselves, so it will kind of like press upon it and then it will create a segment. That segment is what we call the hostra. Now, the first part of the large intestine is the cecum. Here's the cecum, which is the terminal part. Okay. The cecum is 2.5 inches long and it contains the ileocecal valve, which I talked about earlier. Okay. Here's the ileum, here's the ileocecal valve, here's the cecum. And it has something called the retrocecal recess. Okay. So basically, there's peritoneum here. The visceral peritoneum will reflect from the cecum to the anterior abdominal, from to the posterior abdominal wall. So let's say, okay, let's say this cecum, this is like a horizontal plane, okay? Cecum is here. And let's say This is the visceral peritoneum. Visceral peritoneum will reflect upon itself and attach to the posterior abdominal wall and create a recess over here. What is that recess called? Retrocecal recess, behind the cecum recess. Next is the appendix. The appendix, I cannot stress this enough. It's a very, 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 very important structure to know. Okay. The appendix is 2 to 4 inches long, and it may vary. And there's something called it contains the mesoappendix. And what is the mesoappendix? So the mesoappendix, the reason why we've written here false is that it provides partial support to the appendix. So the appendix can still freely move, kind of, okay, but there is support to it via the mesoappendix. And what does the mesoappendix contain? It contains the appendicular artery, okay? And this appendix, okay, it opens 1 inch below the ileocecal valve. Here's the ileocecal valve. Right below it is appendix. Now, where is the most commonly position of the appendix? Retrocecal. Retrocecal. I've seen this in the red files again. Please know that. Okay, the rest, honestly, I don't know if they'll ask you like pelvic, paracolic, whatever. I don't know what they'll ask you, but I've seen retrocecal before. So I know that. And its base is often at Mcburney's point. What is Mcburney's point? This is a very important point. They can ask you easily, like they can give you an appendicitis case, an SAQ, and then ask you, how do you draw Mcburney's point? So you take a line, here's the umbilicus, and here is something called the aces. So here's the pelvis, the aces over here. So you draw a line from the umbilicus to the aces. In relation to the umbilicus, it's two-thirds lateral from the umbilicus and 1/3 medial. Okay? Perfect. Okay. Now, Taenia coli, they meet at the base of the appendix. Fun fact. Okay? Fun fact that you actually need to know. I've seen this in the red files. So, the large intestine is composed of different segments, okay? And there's a lot of information about them, but I'll explain it all on these 4 different pictures. And it's pretty easy, honestly. So first of all, you have the ascending colon, okay? The ascending colon ascends up. Then it goes transversely. It goes horizontally, so it's a transverse colon. Then it goes down, so we call it the descending colon. Then this little part here, we call it the sigmoid colon, and then it will eventually end up as the rectum and continue down to the anal canal. Now, there are some flexures over here. This flexure, we call it the right hepatic flexure or the right colic flexure. So, hepatic in relation to the liver. So, the liver is found over here, so it's inferior to it. Okay. And colic because in relation to the colon. So, you can either call it right hepatic or right colic flexure. On the left side, you have what do you have? You have the spleen. So, we call it the left splenic flexure or the left colic flexure. Okay? So, if you want to see it on this diagram over here, the right hepatic flexure is sitting inferiorly to the liver, okay, and it sits anteriorly to the right kidney. The left splenic flexure sits inferiorly to the spleen. This is the spleen right here, and yeah, okay. Now, how is the splenic how are the flexures also attached to these, to these structures? It's same thing on the hepatic side, but I'm going to talk about the splenic side. On the splenic side, you have something called the splenocolic ligament. So it will connect the spleen to the colon via this ligament. And you have also the phrenicocolic ligament. Phrenico means diaphragm, and colic means colon. So it connect the colon to the diaphragm. Okay? On okay, now for this image. Now, You have the mesocolon, right? It's mesentery. You have the mesocolon. Okay. Now, the only thing I want you to know here is that the root of the mesentery, of the sigmoid mesentery, so we're talking about this part, the root of it lies right over here. It's an inverted V shape. Okay, so it sits like that. It's an inverted V shape. Okay, and it lies at the bifurcation of the common left uh, iliac arteries. Hold on. Yes, at the left common iliac bifurcation. That's the apex of it, okay? And it's anterior to the left ureter. So you'll find the left ureter sitting right behind it, okay? So let's go next. So this is everything that we've said on colonic segments and everything. Everything we said once again. I just added here their inches and also whether it's retroperitoneal or intraperitoneal, because that's very important to remember, okay? Now, let's talk about blood supply for the last part. The blood supply, okay, is a lot, but let's break it down. So, first, let's focus on the superior mesenteric artery. I'm gonna put the color black for this one. Okay. Superior mesenteric artery comes out over here and it continues down and it will divide into three branches. The first branch is what? It's the inferior pancreatico-duodenal artery. That was the trick questions. But for on this diagram, the first branch that it will split into is the middle colic. The second branch is the right colic. And the last branch is the ileocolic. These names derive from what are they supplying? The middle colic will supply the middle. The right colic will supply the right part of the colon. And the ileocolic will supply mainly the ileum and the cecum here. Okay? So it will go down here. This is the ileocolic. The ileocolic will go down, okay? And it will give off a really important artery. And this artery is the appendicular artery. Please know it really well. Ileocolic gives off appendicular artery. And then it will continue up and it will anastomose with the right colic. Okay? Ileocolic will join with the right colic. Then it will go up after giving off some branches to the ascending colon. It will go up and it will anastomose with the, you guessed it, middle colic. So the middle colic over here will run until here. Okay? So all in all, superior mesenteric artery gives off right colic, middle colic, ileocolic. Okay? Ileocolic will give off branches to the ileum and some of the cecum, and it will give off the appendicular artery. Right colic will supply the ascending colon. Middle colic will supply 2/3 of the transverse colon, so right above here. What about the 1/3? Well, this is where inferior mesenteric artery comes into play. So this is inferior mesenteric artery. To give off a branch, which we call the left colic artery. If we have a right, we have a left. And this left colic artery will supply the 1/3 of the transverse mesocolon. So it will supply over here. Okay? And it will also give off branches to the descending colon. And the inferior mesenteric artery will give off other branches, which we call the sigmoid colon, which is right over here. The sigmoid arteries, which will supply the sigmoid colon. All of them will anastomose together to create a collateral pathway. And then eventually the inferior mesenteric artery will continue down as a superior rectal artery. Okay? This is all blood supply in a nutshell. So, there is one thing to keep in mind though. If you notice, the right side is way more, it's more supplied than the left side, especially up here. Here you have two arteries supplying the right side, which means on the left side you only have one artery supplying. Okay? And why am I bringing this up? I'm bringing this up in relation to the splenic flexure. The splenic flexure is poorly supplied. Okay? And that is why we need to take care, especially in surgery, we need to take care on what are we ligating and what are we not, because we do not want to have a risk of infarction. So, this is everything that we just said. I'll just add to it that superior mesenteric artery comes out from L1. Okay, everything we just said. Inferior mesenteric artery comes out from L3, 4 centimeters above the aortic bifurcation. Supplies this, just what we said. And here's a very important clinical note to keep in mind that the splenic flexure is relatively poorly supplied, okay, because it's an avascular area of Rylan. That's like its other name. So we need to have caution during surgery. Now, our last arterial concept for large intestine is the marginal artery of Drummond. Remember when I said all of these arteries will combine together to create a collateral circulation? Well, the marginal artery of Drummond is that collateral circulation. It is formed by the anastomosis of the superior mesenteric artery and the inferior mesenteric artery, and it's all the anastomosis, and it continues along the inner border of the mesenteric, of the mesenteric border of the colon. Okay, and it extends from the ileocecal junction, which is right over here. Remember, the ileum runs over here next to the colon, next to the cecum. So from here all the way to where? To superior rectal artery. And it has some terminal branches which supply the anterior and the posterior walls of the colon. Okay. And lastly, its function is collateral circulation if the main feeding artery is ligated. So let's say you had to ligate an important artery that was supplying all of this. Okay, at least now you have some small arteries still supplying the colon. So, question time. During an appendectomy, a surgeon must locate the appendix. Which anatomical landmark is most useful for this purpose? I'll give you some time to think about this. You can pause the video. All right. So the answer is D. Remember when I said that Taenia coli, they end at the base of the appendix. So this is why the answer is D. Okay, our last concept for the first 3 lectures, the rectum. The rectum is 5 inches long, and it's a continuation of the sigmoid colon. So this is the sigmoid colon. At the level of S3, okay, it continues down as the rectum. And it will end when it pierces the pelvic floor, and that is where it continues as the anal canal. So once it pierces the pelvic floor, it becomes the anal canal. So, features. The lower part, which is dilated, which is right over here, we call this the ampulla. And as well, the Taenia coli, here, they will merge together. So they will merge together and they will create broad anterior and posterior bands. Okay, so you'll almost have a complete muscular coat around the rectum. And it's very important to note there are no haustra, no epiploic appendages, and no Taenia coli. And this is how you know for sure that you are not in the large intestine, because all of these features are features of the large intestine. Now, transverse folds, or what we call the valves of Houston. So they're semicircular, and we have 3. We have the left upper Houston's valve, you have the right middle, and we have the left lower. And what is its function? It supports fecal mass and slow transit. So if you have feces or stool coming down here, it has to go down and then bend and then go down again and then bend more. Okay, so it's a slow transit and it will allow for the expansion, okay, and like hold on more stool. Compared to if you just had a straight tube, you wouldn't have that slow transit going down. So I would imagine that'd be uncomfortable. Okay. So now let's talk about peritoneal covering. Now, the peritoneal covering around the rectum, It's pretty simple. The upper 1/3, so high rectum, okay, you have peritoneal covering from the anterior and from both sides, okay? From the middle 1/3, so somewhere over here, you have peritoneal covering only on the anterior side, only. Okay, and this is where the peritoneum reflects. And once it reflects, that means that we don't have any peritoneum in the lower 1/3 of the rectum. Okay? Now, let's solve our relations. This is very important. I've seen a lot of questions on this. Now, obviously, the female and the males will have different relations anteriorly for the rectum. Anteriorly, for the female, you'll find the pouch of Douglas. Now, the pouch of Douglas is basically the recto-uterine pouch in females, and it is the recto-vesical pouch in males. It's recto-uterine, meaning that is behind the uterus, okay, in females. In males, I couldn't find a picture, but you would have the seminal vesicles running along here, and you'll find the rectovesical pouch right behind it. Same thing. Now, the lower 1/3, okay, is basically separate. The rectum and the lower 1/3 is separated from the vagina by Denon-Villers fascia. So I'll explain it more on this diagram, but this diagram is for males. But it's if you just imagine that you have like here a uterus and then a vagina, this is gonna be a female. So upper for male, same thing, pouch of Douglas, but instead of recto-uterine, it's recto-vesical. Lower 1/3, okay, instead of being separated from vagina in males, it's separated from the bladder, from prostate, vas deferens, seminal vesicles. That is what the rectum is separated by, and it's separated by the same fascia, which is Denon-Villers fascia. So, what I was trying to get at here is that here's the rectum. Okay, here's the lower 1/3. Here is the fascia, and what is it separating? It's separating the rectum from seminal vesicles, prostate, bladder, okay, and yeah. In females, it will separate it from the vagina, okay? Next. Okay, now posteriorly, alhamdulillah, both genders have the same exact posterior relation, so less things to memorize. So, rule of twos again. Two bones, sacrum and coccyx. Sacrum, coccyx. Two muscles, piriformis and coccygeus. Piriformis is right over here. Coccygeus is right over here. Okay? This is like they've taken out the rectum in this image, and this is what you find posteriorly. Two nerves, sympathetic, parasympathetic. And two vessels, which is the median sacral artery, which is right this one. Okay? And the superior rectal, which I cannot find here. And that is it. That's all for my part. I wish you guys all the best on your TBL and also on your final. Inshallah, it's all easy, and Humaira can take it from here.
Assalamu alaikum, guys. So, thank you so much, Leen. That was amazing. Uh, okay. I'm gonna share my screen. Okay. So, I see that Leen has already kind of done the large intestine. So what comes after the large intestine and the rectum? You're gonna have the anal canal. Now, before we start, I just want to mention that this is my first pal, but this is how it's gonna go. Okay, this is how I thought about for myself. You already have slides for every lecture. So it didn't make sense for me to have um the same thing again, as in like images and texts. So what I do to study is usually put everything in tables. So all my slides, majority of the content is going to be in tables. That's just so you can learn easier well and you can differentiate among stuff properly, because they don't ask you stuff which is same. They're always going to ask you differences between stuff. Okay? So that's the first thing. Now the second thing. If you've made it so far in this lecture, you've attended Lean's Pal and now you're going to attend mine. But it's probably because you're cooked. If you have less time, then me and Leen, we both have cram sheets at the end of the presentation. So when we share the presentation slides with you guys can directly go and read those as a quick review before your final. Now let's just get started. Okay, so the anal canal. This is the overview. This is a picture of the anal canal. Wait, let me make this smaller. Okay. So this is the anal canal, guys. Basically this part. Okay. Now what is the position of the anal canal? It is downwards and backwards and passes from the rectal ampulla, which is this over here, to the anus. Now, typically, what we're telling the anal canal is this. You need an entire lecture for this small area. It's a very sensitive area and a very important part for you as well. The length is, as I mentioned, 4 centimeters. Okay. And the angle that the rectum and the anal canal form is 90 degrees. It's a straight angle. Okay. And the key muscle is the puborectalis. I'm going to show you a better picture of the puborectalis, but for now, this is a view from, this is an inferior view. Okay. So like this, we're looking from the bottom down. The puborectalis is also part of the levator ani, and the function of the anal canal is along with the puborectalis to maintain the anorectal angle. Why do we need to maintain the anorectal angle? Because loss of maintenance of anorectal angle leads to fecal incontinence. What do you mean by fecal incontinence? Fecal incontinence is basically when you're you're gonna pass stool faster. Remember how Leen said that if you have a straight rectum, let's say you don't have the valves of Houston, I believe that was what it was. But if you don't have those, there's nothing to keep the stool inside your rectum. Okay? So if the anal canal is also straight, imagine it just flows through, and when you don't want to pass stool, you're just going to end up passing stool. So this is fecal incontinence. This happens when your puborectalis muscle basically collapses or the anorectal angle for some reason is not maintained anymore. Okay. And by the way, everything in red is clinically significant. And for Dr. Akef's slide, it's usually the clinically significant stuff that he's going to mention. Everything in my slides is correlated with the transcriptions, the 18 batch lecture recordings, and the red file. Okay. I haven't mentioned it explicitly anywhere, but I've not included any of the stuff that's not being emphasized by our doctors, basically, or in the history of Al-Faisal. Okay, now the location and the relation of the anal canal. This is the anal canal. What do you see in front of it? You see, as an anterior to it, you see the perineal body. What's posterior to it, you're going to see the coccyx. Okay, this is the anal-coccygeal body, and this is the perineal body. First of all, we're going to get more into detail about the perineal body, so don't worry about that. But the anal-coccygeal body, you can get questions in 2 types for this. You're either they're going to give you the anal-coccygeal body, which is mentioned straight up in your slides, or it's going to come as a coccyx, which is just to trick you, but it's this. That's the answer, okay? Superiorly, we said we have the rectal ampulla, and inferiorly, obviously, you cannot close the anal canal, because if you close the anal canal, what's the point of having an anal canal? Okay, now, what is a perineal body? It is a fibromuscular central tendon of perineum. What is a tendon? It's white collagen bundles. It's very strong. It's very adherent. It's where muscles meet, all the muscles meet, and then they form this tendon kite sheet. And the fibers of the levator ani also meet here. And the main job of the external anal sphincter and the main job of the perineal body is to support the external anal sphincter and to prevent prolapse of the organs. What do you mean by prolapse of the organs? I don't remember very well if this was mentioned in your lectures, but this was mentioned in our lecture from our time, I remember. So basically, when the perineal body is damaged for any sort of reasons, usually is due to childbirth, you're going to have prolapse of the organs inside because the perineal body is here, as you see. Okay, so imagine that this is a female patients. Okay, so you're going to have the uterine pouch here. Okay, so if this perineal body tears for maybe because of childbirth, the uterine pouch is going to drop down. That's called organ prolapse. It's something that you guys should definitely keep in mind because this is mentioned repeatedly in all ears. The clinical significance of the perineal body is that during rapid or difficult child delivery or labor, the perineal body can tear, and the tear may extend into the external anal sphincter, as in until here, okay? Or the tear may extend until the anal canal as well. So you're gonna have basically it's gonna be a bigger anal canal, which can obviously call what? Fecal incontinence. Now there's something called episiotomy, which is what doctors do before childbirth if they see that the circumference of the head of the baby is too big and it's difficult to push it through without tearing the episiotomy, and or there's risk of tearing the episiotomy. It's better to surgically make a clean cut rather than disrupting the perineal body. Because if the perineal body, imagine it tears like paper, like not clean edges, then what's gonna happen? You're not gonna be able to suture it well because it's spread apart. But if you cut it in a linear way, in a linear fashion, in a clear way, you can obviously always seal it back. Now, moving on. The anal columns. These are the anal columns. They are also called as the columns of Morgagni or something. Okay. There are 5 to 10 arteriovenous mucosal cushions. So you see these are going to be 5 to 10. And each one of these mucosal columns is going to have an artery and a vein. Okay. And they kind of cushion your anal canal. Um, Now moving on. Okay, and they're connected to flaps called the anal valve. We're going to discuss the anal valve as well. But what is the clinical importance of anal columns? Is that the internal hemorrhoids. We're going to go into a lot more detail in the future slides. But basically, when there's pooling of blood in the anal columns, the mucosa becomes loose, and then you're going to have hemorrhoids because that's basically dilation of veins. Okay, in simple words. Keep in mind that anal columns are the columns of Morgagni. They're 5 to 10, and each column has an artery and vein. And internal hemorrhoids takes place in the anal columns of Morgagni, and the blood comes from the internal rectal plexus, which is also high yield, but it's gonna come in the slides again. Okay, anal valves. These anal valves connect the anal columns. As I mentioned, they are the flaps that close the anal column, just so you don't have fecal incontinence again. And the anal valves also form the lower border of the pectinate line. So this is the pectinate line. These are the anal valves. So the anal valves form no, wait, this is the pectinate line, and these are the anal columns. So this is going to form the lower border of the pectinate line. Okay. And then you have the anal sinuses. What are the anal sinuses? I'm going to show you a picture again. Wait, I think it's on the next page. Yeah, okay. Anal sinuses as well. There are depressions between the valves. I'll show it to you on the next page. And what happens is when fecal matter gets stuck between these anal sinuses, you're going to have infection, anal abscess, not high yield. Don't worry about it. Pectinate line. Pectinate line, guys. Keep this in mind. After the pectinate line, everything changes. And the pectinate line is what divides the anal canal into 2 parts, the upper half of the anal canal and the lower half of the anal canal. Now, this is the column of Morgagni, where internal hemorrhoids take place. As you can see, this is reddish bluish. This is because the anal columns have, I'm hoping you say, arteries and veins. And these are the anal sinuses. Okay, you see how da 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 and da. So this is gonna be the anal sinus. And what happens is there's fecal incontinence. Sorry, there's fecal matter that gets stuck in this because the fecus is gonna come from here. Okay. Imagine like doo-doo. Okay, like you have fecal coming here, fecus coming here, feces, and then it gets stuck here in between these. And that's what causes abscesses. But that's not important. Don't worry about it. This is the pectinate line. The pectinate line, again, where is it? It's forming the, I don't know why it says lower border in your slides as well, but I really think it was the upper. Okay, anyways, but this is the pectinate line or the dentate line. Now, another thing that I want to mention is wait, how do you, stop. Okay, so moving on. Over here, I want you to focus on a bunch of stuff. I'm going to share these slides with you as well, inshallah. And everything that has a red dot is what you need to know and is what Dr. Akif mentioned. The anal sinuses, the anal valves, The anal valves are gonna be here. They're what are below the column of Morgagni, which is also what you need to know. The pectinate line, also known as the dentate line, which separates the upper half from the lower half. The anorectal junction. So this is going to be the rectum, and this is going to be the anal canal. And I need you to know what I was going to show you guys is the levator ani. So it's this one. Okay? This is the levator ani. And then you're going to have inner circular muscles and outer longitudinal muscles of the rectum. This is also very important. Then you're going to have this is the deep external anal sphincter. So you have two external sphincters. You have the deep external anal sphincter and you have the superficial external anal sphincter. And then you have the internal anal sphincter. Okay? And you also need to know the subcutaneous external anal sphincter. Okay? So this is going to be the most outwards or more towards the dermal surface, the subcutaneous external sphincter. Then you're going to have the internal, then you're going to have the superficial external anal sphincter, and then you're going to have the deep external anal sphincter. For the internal anal sphincter, you have this one. This is the internal anal sphincter. And then it comes down from the circular muscles of the rectum and the longitudinal muscles of the rectum. Okay, and this is the levator ani. The levator ani has very high yield. It's on OSPs, on images, everywhere. Okay, now the anal canal, upper half versus lower half. Let's do it in the table form first, and then we can move on to more image kind of way. Okay, so first of all, what is dividing the upper and lower half? The pectinate line. Keep that in mind 24/7. Okay. The origin of the area, the embryological origin of the area above the pectinate line, which is the upper half of the rectal anal canal, is the endoderm. What's for the lower half? It's the ectoderm. The epithelium in the upper half of the anal canal is going to be columnar. However, for that of the lower half is going to be stratified squamous. Stratified squamous, guys. Dr. Annie, if you guys know, stratified squamous is when you feel things. So you guys have stratified squamous to feel things. So this is also something that you want to keep in mind because the upper half is supplied by autonomic nervous system, which means it's not in our control. However, the lower half is by the somatic, which we can control. Okay? And the sensations in the upper half, distension and ischemia. Why can't you feel pain or touch over here? Because the epithelium first is columnar. Second, the nerve supply is autonomic nervous system, which is a hypogastric plexus. And if you guys have attended Dr. Akef's lectures faithfully, he always asks this question once in any lecture where every student gets flabbergasted. He's like, what kind of pain can you feel in a place where there's no sensations? Like, why do you feel pain in your abdomen sometimes? Or why do you feel pain in your large intestine kind of place sometimes? What happens? It's not pain because something's touching there. Like, for example, if I'm pinching something here, it's not pain because of that. The pain is because of either distension or because of ischemia, which is loss of oxygen to that organ. And then you have lower half of the pectinate line, you're going to have pain, touch, and temperature, which is what? Basic skin sensations. Okay? Basically, it all makes sense. The ectoderm, superficial most layer of the skin. That's the reason is the lower half of the pectinate line, closer to the it's more superficial. Okay? And then you have the stratified squamous, again, an epithelium which is more superficial. Somatic innervation, obviously, it's kind of more superficial. Inferior rectal nerve, pain, touch, temperature. Why am I mentioning this again and again? Have an idea. Okay. The lower half, the upper half artery, superior rectal artery. Now, if you have a superior, you have an inferior, and the lower half is inferior. Super easy to remember because up, superior, lower, inferior. Veins. Now, the superior rectal vein drains into the inferior mesenteric vein, which further drains into the portal vein. The lower half, inferior rectal vein, again, superior, inferior, lower, which is a tributary of the internal pudendal vein, which you have to remember, this is repeated. And it drains into the internal iliac vein, which then drains into the inferior vena cava. Okay? The lymph nodes, so the upper half drains into the pararectal inferior mesenteric nodes, pararectal and inferior mesenteric nodes. And the lower half, lymph drains into the medial groups of the superficial inguinal nodes. Hemorrhoids, you have upper half, you have, okay, in the upper half, remember how we had the columns of Morgagni? This is where the hemorrhoids come in. So the columns of Morgagni are inside, are internal, and they're in the upper half of the anal canal. So you can't feel pain in these, okay? These are going to be internal hemorrhoids, and you can't find pain in these. How do you diagnose these? By blood and mucus and stool. Thrombosis is rare. However, when it comes to the lower half of the anal canal, and when you have hemorrhoids over here, it's very painful. Sometimes people can't sit down. And one of the things that Dr. Akef and Dr. Atif both like asking is that, how do you have hemorrhoids? It's usually when people sit in the toilet for too long. This is something that he mentioned. I don't know if he's going to ask you guys, but I think this is like a kind of a clue. Or it happens to old people, okay, because their blood pooling and stuff. Okay. And the lower half, the thing is, it's going to be very painful, but it's going to have no blood. So let's say you have a case scenario in which a person comes with pain in the anal canal and is not able to sit. What is it? It's going to be the external hemorrhoids. If they come and they tell you, I have no pain, but I noticed stool in my blood. I noticed blood in my stool. What are you going to say? It's going to be internal hemorrhoids. Okay. Again, pectinate line. Da, da, da. Same thing, guys. I love this slide. You're going to get a lot of questions from these. If you're familiar with this slide, you don't need anything else. You're going to have the internal rectal venous plexus. This is what we said. The inferior rectal veins, which are here in the columns of Morgagni, will drain into the internal rectal venous plexus. Okay, and pooling of blood takes place here. Okay, in the internal rectal venous plexus. Do you remember? I mentioned it here. Look, it drains, pools in the veins from the internal rectal venous plexus. Again, it's basically the same thing, levator ani, the exact same slide, guys. Now, something that I want to mention is, if you guys notice that the upper half, the venous supply drains into the portal vein, which is basically you're entering the portal circulation. The lower half drains into the systemic circulation, which is normal. But this is into the portal circulation. So you're having a portosystemic circulation because the rectal vein is a systemic vein, but it's draining into the portal vein. So you have a portosystemic venous connection. This is very important, high yield, a connection between the portal system, liver circulation, and the body's systemic circulation. This connection becomes active when there's obstruction in either one of the systems. Now, let's say that you have an obstruction somewhere in the systemic circulation. These portal circulations or the portosystemic anastomoses are created so the blood isn't just like, so that there's some alternate path to take when the blood supply isn't reaching to the required organ. Now, the issue here is that these alternate routes are not very big, okay, because they were hibernating. You didn't need them unless you had an emergency. So these are very tiny. So when systemic blood starts pooling in them, they get dilated. And what happens when veins get dilated? You get varicose veins. What happens when you get varicose veins in the anal canal? It's called hemorrhoids. Okay? So the portal hypertension causes dilated superior rectal veins, which causes internal hemorrhoids. Why? Superior is always related to superior, upper half, internal hemorrhoids. Inferior, lower half, external hemorrhoids. Think about it this way. Now, the portal side is the superior rectal vein, inferior mesenteric. I have a better slide for this, for the arterial supply, this one. Now, we all know arteries carry blood to the part. So, I'm going to talk briefly about how this is going to work. You have the inferior mesenteric artery, which gives a branch called the superficial rectal artery, which supplies, it's superficial, guys, so it's going to supply the upper half of the anal canal. Internal iliac artery gives a branch called the middle rectal artery, which supplies the muscular wall, the prostate, and the seminal vesicles, and this is often absent in the females. This is something which was highlighted in yellow in Dr. Akif's slides, which basically means that he didn't mention it well in the class. However, since it's highlighted in yellow, he wants you to know. Okay? So the internal iliac artery, emphasizing again, internal iliac artery gives the supplying artery, middle rectal artery, which is usually absent in the females. However, supplies the muscular wall, the prostate, and the seminal vesicles in males. Now you have the internal pudendal artery, which gives rise to the inferior rectal artery. What does the inferior rectal artery supply? Inferior, lower half of the anal canal. Median sacral artery, that was honestly never mentioned it in class, to us at least. It's just on the slide. But it's just there for completion's sake. Now the venous supply. What do the veins do? They collect stuff from organs. So we're going to go in the opposite way now, okay? So for the upper half of the anal canal, the superior rectal vein collects blood, deoxygenated blood, from the upper half of the anal canal and drains it into the inferior mesenteric vein, which further drains it into the portal circulation. The middle and lower half of the anal canal is drained by the middle rectal vein. So keep this, guys. Keep this in your mind, guys, please. Upper superior rectal vein, middle and lower is middle rectal vein. Lower is inferior rectal vein. Okay? The middle and lower half of the anal canal is going to be the middle rectal vein, which then drains it into the internal iliac artery, which further drains it into the IVC. Okay. And the lower half of the anal canal, again, inferior rectal vein collects it and then drains it into the internal pudendal, which further drains it into the IVC. I hope this makes more sense now because the superior rectal vein drains into the inferior mesenteric vein, which drains into the portal vein. The reason this is in a table is because I want you to know that for the portal side of the circulation, you have the superior rectal vein, and for the caval side of the circulation, you have the inferior rectal vein. Now, moving on, lymph, very cute patoot. Above the pectinate line, you have the pararectal and inferior mesenteric, which is basically the upper half of the lower canal is going to be drained by the pararectal and inferior mesenteric, and the lower half and below the pectinate line is going to be the medial group of the superficial inguinal nodes. Something that I want you to keep in mind is that here it's roles reversed. Until now, we kept saying that above the pectinate line, everything is superior, upper, and whatnot. If you notice here, you have inferior written. So above the pectinate line, although it's the upper half, it is the inferior mesenteric lymph nodes. Please keep this in mind. And then below pectinate line, you're going to have the medial group of the superficial inguinal nodes. Again, keep this in mind. This is very important. Cancer above the pectinate line spreads to the inferior mesenteric node. So let's say you have cancer in the upper half of the anal canal. Which lymph node is it draining to? The inferior mesenteric node. Why am I stressing on this? Dr. Akef stressed on this. All right. Next, anal sphincters. Anal sphincters, you're going to have, again, one in the upper half of the anal canal, and the next one's going to be in the lower half of the anal canal. So the upper half of the anal canal, remember we said autonomic nervous system, columnar epithelium. Basically, you can't feel pain. So what type of muscles do you think are going to be there? They're going to be smooth because you can't control autonomic nervous system, right? So it's automatic. Okay. Now, the type of muscles in the internal sphincter or okay, by the way, the internal sphincters are present in the upper 2/3 of the anal canal, not on the upper half. This is important. Please keep this in mind. Where are the internal sphincters? Upper 2/3 of the anal canal. Where are the internal sphincters? Upper 2/3 of the anal canal. Where are the external sphincters? Lower 1/3 of the anal canal. Capiche? All right. So the smooth muscle, so internal sphincter, which is on the upper 2/3 of the anal canal, is gonna be the smooth muscle, okay? And then the external sphincter is gonna have skeletal muscle. Why? Because skeletal muscles are voluntary, all right? Now, what are the innervations? You have internal sphincter is innervated by the inferior hypogastric, and the external sphincter is innervated by the inferior rectal, which is a branch of the pudendal. Okay, please. Pudendal, again, we saw this in another place. That was also in the inferior, that was the inferior rectal veins, which were a tributary of the pudendal vein. Keep this in mind. So you have pudendal again in the lower anal canal. Something not extra, but this is something that you have to keep in mind, is that the internal anal sphincters can be marked by the white line of Houston. I'll show you on the image right now. And then the external anal sphincter, you have three. As I mentioned before, you have the subcutaneous, which is the most superficial, and then you have the superficial, and then you have the deep parts of the sphincter's musculature. But the deep muscle fuses with the puborectalis. There's a good picture over here. Here. Okay. This is the superficial part. You see how it's in the middle? This is the subcutaneous part. So these are all the external sphincters. These are the muscles, okay? The subcutaneous part, the superficial part, the deep part. But do you see? Do you see what this muscle is? Can you guys recognize this? This muscle is this muscle. Okay? So you see how this is the levator ani, how it says this is the levator ani, this is the levator ani, and the deep part fuses with the levator ani. And then you have the superficial, and then you have the subcutaneous part. All right? These are all for the external sphincters. Now, moving on, you have the inferior rectal nerve, which not important, low-key. It's a perennial branch and whatnot. Somewhere over here. It's not important, okay? This is the superficial external sphincter again. This is the subcutaneous. I wish I had a smaller pointer. Okay, yes, this is subcutaneous, this is superficial, and this is the deep. This is very important. Moving on. Here, I would like you to see the internal anal sphincter again, which is this one. Okay, we have one internal anal sphincter. We have three external anal sphincters. And for the white line of Houston, here you go. Now, what is this, guys? Is this the white line of Houston? No. No, 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 no. This is the white line of Houston. These are the columns of Morgagni. What did we say are near the columns of Morgagni? The pectinate line. The pectinate line is not equal to the line of Houston. Please keep this in mind. All right, moving on. This is the white line of Houston. And these are something that you need to keep in mind. The white line of Houston is also called the intersphincteric line because it is between the internal and external sphincters. This is the internal sphincter, okay? This one. This is going to be the internal sphincter. And the external sphincters are going to be here. But makes sense. So it's going to separate. These are the internal sphincters, the white line of Houston or the intersphincteric line, and the external sphincters. I think I call this external, this is internal. Don't worry about it. Now, it does not separate the upper half from the lower half. Why? Because the internal sphincters are present. Do you see how low this is? This is definitely not half. This is half, but this is not half. This is the lower 2/3, and this is the upper 2/3, upper 1/3. This is the upper 2/3, and this is the lower 1/3. Ah, my favorite slide. Okay, this is the final slide and the most high yield slide. This is anal incontinence. Sorry, fecal and anal canal incontinence. So we said that the fecal continence, that the fecal has, you can't have fecal incontinence, basically. You need to have control over your fecal matter and over your sphincters and over like choice when to pass it out. So this is a mnemonic for you guys. To close the anal canal, you use the mnemonic close, okay? To close the anal canal, you need C, column of Morgagni, which are the mucosal cushions that seal the canal. L, levator ani, or the puborectalis, which maintains the 90-degree anorectal angle. O, outer or external sphincter, voluntary control. S, smooth muscle, internal sphincter, involuntary control. E, endorectal folds, which are also known as the valves of Houston, which holds the fecus in the rectum. I hope this helped you guys because that is the end of the anal canal lecture. I hope you understood that. If you were here, I would ask you 100%. Here's the first question. A 27-year-old male presents to the ER after bleeding through the anal canal, dark red colored blood. Swollen blue vessels can be observed in this patient. Which of the following can be responsible? He's noticed bleeding in his stool, basically. So what is it going to be? I'm going to give you guys 3 seconds or you can pause it. 3, 2, 1. It's going to be internal hemorrhoids, okay? If you don't notice blood, it's going to be external hemorrhoids. If he would say immense pain in the anal canal. It's going to be external hemorrhoids. Moving on to the anterior abdominal wall. Take a break or lock in. All right. Anterior abdominal wall. First, let's orient ourselves. The abdominal wall boundaries. So, what is the what are the boundaries of the abdomen in the first place? Is the region between the diaphragm and the pelvic inlet. Okay. And the anterior boundary is formed by the lower thoracic cage and the abdominal muscles, which I'm pretty sure all the guys out there have well built. And the posterior boundary is by the lumbar spine and the psoas major and the quadratus lumborum. Not too high yield. Don't worry about it, but you do need to know about the psoas major part. This is kind of high yield. Okay. Also, not just guys, girls have abdominal muscles as well. Very cool ones. Okay, now, this is the linea alba. This is, again, I want you to just orient yourself over here. This is what you would look like if you would have a six-pack body. You would have six packs. Okay. The linea alba would be the one in the middle. It would be a whitish line. And then you have the rectus abdominis muscles, which are the six packs muscles. And then you have the linea semilunaris, which are the borders of the rectus abdominis muscles. You have the umbilicus scar, or the belly button. And you have the arcuate line, which is again a lighter whitish color line, which basically marks the end of the posterior sheath. It basically covers this. Okay, now again, briefer description of every one of these. I mentioned all of this, so I'm just gonna go into the clinical importance. Fun fact, or very important clinical fact, is that the linea alba is the best place to make a bloodless incision because it has very poor blood supply. You might think that it's a bad thing to have poor blood supply, but surgeons use this to their benefit. But this is where they could make a clean straight line. This is something important. It was mentioned by Dr. Olena. All right. Now, the rectus abdominis, six pack does not mean six muscles, guys. It's just the rectus abdominis is like a paired muscle kind of thing. Okay. The tendinous intersection creates the six packs contour. These are the tendinous intersections. Okay. Linea semilunaris are the lateral rectus borders. Again, the clinical importance would be in this spiglinia hernia. I tried a lot to spell it, but I really can't, so I'm just giving up now. The umbilicus, it lies in the T10 dermatome. This is very important. You're going to keep taking this until like time immemorial. The arcuate line is also a place which is at risk for hernia because it's where the posterior sheath ends and where something called the inguinal canal usually lies. This is something that Leen already went over. However, because this is also mentioned in the abdominal wall and you didn't lock in with her, you can just refer to this again. This is the right upper quadrant, the left upper quadrant, the right lower quadrant, and the left lower quadrant. These are the organs that you would see. This is very important. You would obviously see the pancreas behind this as well, as Leen mentioned earlier. And you have, yeah, this is all you have. So I've mentioned this again. So the right upper quadrant is where you would have cholecystitis because the liver and the gallbladder are present. Left upper quadrant is where you would have splenic rupture because the spleen is present in the left upper quadrant. The right lower quadrant is where you have the cecum, and the appendix is usually located here, but not always, as Leen mentioned. And you can also have the appendicitis over here because of that. And the lower left quadrant has the sigmoid colon or the diverticulitis, which again, Leen mentioned, but you have to lock in there first. Next, you have referred pain. These are all the regions of referred pain. Now, first of all, this is what you have to orient yourself with. How did we draw these lines? Like, I'm not going to put a patient under a cannula and draw lines on them. But I'm going to have to use some kind of markings. The vertical lines are drawn as a continuation of the mid-clavicular lines from the chest wall. And the horizontal lines are the lateral margins from the rectus abdominis muscles or the semilunar lines. Remember how the guy had six packs? But not these lines. We're going to mark these lines, like the one that made the steps. Okay, now, the referred pain, you have pain arising out of the four gut-derived structures. So you have the embryological regions. You have this would be the foregut, the midgut, hindgut derived structures. Okay. The blue line that is over here, the dotted blue line, is just to orient you guys with also the So this would be the right upper quadrant, the left upper quadrant, the right lower quadrant, and the left lower quadrant. Does not mean that we're not going to orient ourselves with those. Those are the basics. But these are how we further divide them to kind of localize the pain. Let's say that you have referred to epigastric region. Okay. So let's say the pain is over here in the epigastric region. That would kind of say that you have a gastric ulcer because the stomach lies right over here. If you guys remember from the previous slide, look, the stomach lies here. It would be in the epigastric region over here as well. Okay, this is the reason why we're doing this. Referred pain is a very important topic, guys. Wherever the organ is does not mean the pain has to be there. It can be somewhere else as well. The midgut derived structures are referred to the umbilical region. Early appendicitis and stuff, you're going to find the pain over here. Hindgut derived structures is going to be this. So it's pretty easy to remember this because foregut, midgut, hindgut. Now lock in. This is the layers of the anterior abdominal wall. This is something that people get very confused of. This perfect picture that I found online is going to help you. And I use the same picture for my lectures as well. This is the skin. Unfortunately, this guy has jaundice, I believe. His skin is yellow. Anyways, this is the skin. Underneath the skin, you have the superficial fascia, or sorry, yeah, you have the look. Under the skin, you have the superficial fascia, which is the fatty layer, or it's also known as Camper's fascia. You have to know Camper's fascia, you have to know the name. Very important. No one calls it superficial fascia. They all call it Camper's fascia because you have two types of superficial fascia. First is the Camper's, second is the Scarpa's. So Scarpa's is the membranous layer. You see this white kind of line? That's going to be Scarpa's fascia. But after that, you have the you're done with this, you're gonna have this. You know what? Let's go to this one first. Because this is like giving like better layout. Okay. So this is the skin. This is the Camper's fascia, which is the fatty superficial fascia. This is the Scarpa's fascia, which is the membranous superficial fascia. Then you don't need to know the superficial investing fascia. However, what I do need you to know is that every muscle has a fascia. Capiche? Every muscle is covered by a fascia. But this is the external oblique, so it's covered by a fascia. This is the middle. Oh, this is the internal oblique, and this has a fascia. Okay. And then this is the what's it called? Transversus abdominis, like this. Yeah, this is the transversus abdominis, and this also has a fascia. The fascia below the transversus abdominis is called the transversalis fascia. Okay, the transversalis fascia is very important. It has one slide for itself. And then you have the extraperitoneal fat, and then you have the peritoneum. Do not confuse the fat with both of these. You have two fatty layers. This is the actual fat and the extraperitoneal fat. This is the parietal peritoneum, and this is Camper's fascia, or the superficial fascia's fatty layer. So right under your skin, the first thing you have is fat, thin layer of fat, not as thick as that's showing here. Again, on this, if you want to see it again, this is going to be the skin, the superficial fascia, fatty layer, Camper's fascia, superficial fascia, membranous layer, or Scarpa's fascia. You're going to have the external oblique muscle, which is going to be, this is the external oblique, guys, the outermost one. It's going to be covered by a fascia. Internal oblique is also going to be covered by a fascia, and then you're going to have the internal oblique. And then you're going to have the transverse abdominis muscle, which is also going to be covered by a fascia. And under the transversus abdominis muscle, you have the transversalis fascia. But the transversalis fascia, this is what I was talking about, is the first layer to be affected by hernia. Okay? It's basically, it enters the hernia. It's the first one to enter the hernia. And the hernial sac lies in the extraperitoneal fascia. Do you remember how the extraperitoneal fascia was in front of the parietal peritoneum? This is where the hernial sac lives. But the hernia itself is a part of the parietal peritoneum. So you need to remember all of this, guys. Parietal peritoneum is where the hernial sac is formed. The extraperitoneal fascia is where the hernial sac protrudes into. And then the transversalis fascia is what is the first layer of the skin to get affected by the hernia. These are the abdominis muscles. This, honestly, guys, I tried to think about how to make it easier for you guys. I really couldn't. I can help you organize yourself with this, but it's just this is all just memorization. Okay. So, but you have to memorize. That doesn't mean that it's just memorization. You have to memorize, especially the external oblique. The external oblique, Dr. Olena especially mentioned in her lecture in your class that she will get questions from external oblique, from learning the external oblique well, at least if you're scared of all this. But this is the rectus abdominis. First of all, the rectus abdominis is covered by the rectus sheath. Remember how yeah, you remember it. Don't worry about it. Okay. The linea alba is the middle line. The linea semilunaris would be these lines. And then you have the rectus abdominis. Below the rectus abdominis, we said that you have the external oblique. These are going to be the external oblique. Okay? And then you're going to have the internal oblique. Wait, the external oblique are on top of the rectus abdominis. The external oblique, then you're going to have the internal oblique. Then you're going to have the transversus abdominis. And then you're going to have, I think that's it for the slide. And then you're also going to have the pyramidalis, which is not below anything. It's just the rectus sheath is here, the rectus abdominis is here, and then on top of it, you'd have the pyramidalis muscle. You're going to need to know all this by yourself, guys. I'm so sorry. It's just what I can help you with is that external abdominal muscle helps you go this way. Like, that's the only thing I know. I mean, I know the other part as well. Also, the aponeurosis, this is very important. The aponeurosis is um where all the muscles meet, like the muscles tips or the ends of the muscles, they join to form an aponeurosis. Okay, the innervation. The neurovascular plane lies between the internal oblique and the transverse abdominis muscle. Going back, internal oblique and the transverse abdominis, you would have the neurovascular thing come from here, the neurovascular plane here. What lies in the neurovascular plane? You have one artery, one vein, one nerve. Okay. Um, you have 7 nerves, which and easy to remember. You're not gonna have to remember different nerves. 7 nerves are the 7 lower thoracic nerve, the remaining half of the thoracic nerves. So it's gonna be T6, T7, T8, T9, T10, T11, T12, L1. Wait, T7, T8, T9, T10, T11, T12, L1. How did it become 7? Yeah, it's 7. Yeah, it's 7. Okay, fine. That's fine. Okay. The L1 can be anesthetized by injecting 1 inch above the anterior superior iliac spine. Why would you need to know why L1 needs to be anesthetized? Is because L1, do you see this? Do you see this circle here? Yeah, that's actually the inguinal canal, guys. The L1 passes through the inguinal canal. But sometimes to treat the inguinal canal, you're going to need to anesthetize the L1 because that's how you're going to feel the pain. So to anesthetize it, you're going to have to inject 1 inch over it, which is near the anterior superior iliac spine. That's the marking for the L1 nerve or the ilioinguinal nerve, and you're going to go 1 inch above it and give the anesthesia there. Again, this is just memorization. You're going to need to know this, the superficial epigastric arteries. You have superficial arteries, which supply the skin, and then you have deep arteries, which supply through the neurovascular plane. Again, T7, T8, T9, T10, T11, T12, L1, and T6. You start from T6. Okay. So you have important deep arteries, which lie in the neurovascular plane as well. You have the superior epigastric, you have the posterior intercostals, you have the lumbar arteries, deep circumflex artery, iliac arteries, inferior epigastric arteries. You have the superficial arteries, which are like superficial epigastric and superficial circumflex iliac. Now, here's the thing. They're not going to get these arteries or anything related to these arteries from this lecture, but they're definitely going to get something related to these arteries from your other lectures where you guys have already taken them. You're gonna have to know a few of these arteries. Like these 2 arteries are very important, and you're gonna have to know. For example, they're gonna ask you that the surgeon made an incision in the superficial layer of the skin and could not find this found this artery in the superficial part of the skin, superficial surgical incision or whatever. So which of these arteries would be there? But they'd give you all the options of these, and then you'd have to choose superficial epigastric or superficial circumflex iliac artery. Veins above the umbilicus, the veins drain into the axillary vein, And below the umbilicus, they drain into the femoral vein. From the umbilicus, above the umbilicus, they would drain via the axillary vein into the lateral thoracic vein, and above the umbilic and below the umbilicus, they would drain into the femoral vein and then into the superficial epigastric and the great saphenous vein. And the paraumbilical veins connect the network through the umbilicus along the ligamentum teres and falciparum ligament in the deep portal vein, and the deep veins follow the arteries. Deep vein follow the arteries, as in these deep veins would be these. Okay. Honestly, never seen a question from here. Never. But never say never. So if you want to go over it to be safe, I would advise you to do that. This, however, is important. Above the umbilicus, you're going to have the axillary lymph nodes affected. Below the umbilicus, you're going to have the superficial inguinal nodes affected. In the case of cancer, they're going to give you a case about cancer, most probably, where the dude has something like a cancer somewhere over here in the abdominal wall, which is an area above the umbilicus. And then they will tell you, where would this lead to? Where would which lymph nodes would be affected? Okay, they're not going to say what lymph nodes drain this area. They're going to say which lymph nodes are going to get affected, or most likely to get affected. But you have to choose anterior axillary lymph nodes. And if it's below the umbilicus, you're going to have to choose superficial inguinal nodes. Also, question, which part of the anal canal um, was drained by the median groups of the superficial inguinal nodes? 3, 2, 1. It was the lower half, guys. Good job. The rectus sheath. Now, the rectus sheath was this. Okay? This is the rectus sheath. Now, above the arcuate line, the rectus sheath is anteriorly covering the external oblique, the internal oblique, and posteriorly it's covering the internal oblique and the transverse fascia. Why are we knowing this? I did not add that. There's a slide, Dr. Olena's slide. There's this sheath. Okay. The rectus sheath is not like one paper. How do I say this? Okay. The rectus sheath is not going to be one paper. The rectus sheath is like this. Okay. But things pass through this. So anteriorly, what is passing through above the arcuate line? You have the external oblique and the internal oblique anteriorly. Posteriorly, you're going to have the internal oblique and the transverse fascia. Below the arcuate line, you're going to have external oblique fibers, internal oblique fibers, and the transverse fascia fibers. And below the arcuate line posteriorly, you're going to have transverse fascia. Something you want to keep in mind is that the external oblique fascia muscles, you know how all muscle fibers diffuse together, so whatnot. External oblique does not do that. Why? The external oblique, rather than forming like a like a okay, I'm gonna draw this. The external oblique, rather than forming a muscle like this, like a muscle connection like this, they go down and they narrow down, but they never meet. They're like parallel lines. They keep going down, they keep going down. And this area, what they keep going down, forms the inguinal canal. Okay? This is it. This is the inguinal canal. The length of the inguinal canal is 4 centimeters. The male inguinal canal contains the spermatic cord, whereas the female content is the round ligament. There was also a mention about a cremaster muscle, but that's in their slides. No external resources say cremaster muscle. But I'm pretty sure it's there for men. Okay. The nerve, which is going to pass through, again, I said the L1 or the ilioinguinal ligament would pass through, and the weak area or the common weak, and this is a weak area or also known as the common hernia site. So you're going to hear inguinal hernia. You're going to have a lot of hernias over here. Okay. So again, this is what I was talking about. This is the inguinal canal, this part. This is going to be the superficial inguinal ring, and this is going to be the internal inguinal ring. Okay. Now, this is the peritoneal bulge. You don't need to know about that. You just need to know that this is the deep inguinal ring and this is the superficial inguinal ring. What passes through? L1 and the spermatic cord and the round ligament and the deep inguinal ring, which is this one, opens in the transversalis fascia. You need to know this. Where does this open? In the transversalis fascia. And what is the landmark to remember this? You're going to have the lateral and the inferior epigastric vein vessels. Lateral to inferior epigastric vessels. For the superficial inguinal ring, it's going to open in the external obliques aponeurosis. Okay? And the landmark would be above the pubic tubercle. You know what? Let's just go back real quick. Can we go that back? Yeah. Okay. Think about it. Somewhere here, guys. Okay. It's going to be, this is obviously the bottom of the thigh, but not on the bottom of the thigh. It's going to be on top of the thigh, and it's going to be on the pubic tubercle. Okay. I should have put in a proper picture of the slides. But I didn't think I would have to until I started. Okay, that's okay. This is the extraperitoneal fascia. Again, as I mentioned, that this is what's gonna form the wall. If you know what I mean. The extraperitoneal fascia we said would be a wall. Now, and the walls of the inguinal canal would be the anteriorly, you have the external oblique aponeurosis. Posteriorly, you have the transversalis fascia and the conjoint tendon. The conjoint tendon is nothing but the internal oblique fibers continued. Okay? The roof is the internal oblique and the transverse abdominis. The floor is going to be the inguinal ligament, which is going to be, what is the inguinal ligament? It's just the extension of the external oblique. So the inguinal ligament, what is the inguinal ligament in, if someone asks you, what is the inguinal ligament? It is basically the aponeurosis of the external oblique, which is just continued. Remember how I said that it keeps going and going and going? When it keeps going, the thing that's being formed on the floor of the inguinal canal is going to be the aponeurosis of the external oblique. It's just the inguinal ligament is just that. It's nothing by itself. You know what I mean? But this is the inguinal canal. These are the transverse fascia, posteriorly inguinal ligament, inferiorly external oblique aponeurosis, anteriorly. This was in Dr. Olena's slide. Wonderful slide. Wonderful woman that she is. Direct hernia, Hasselbalch's triangle. Now, you have two types of hernias, guys. You have direct and you have indirect. Where did the difference between direct and indirect go? Okay, maybe it's coming up. Yeah, I'm gonna go to this slide first, and then I'm gonna go to the previous one, okay? So this is the direct inguinal hernia, and this is the indirect inguinal hernia. You have the direct here and the indirect one here. What is the difference? The direct one, the indirect one, which is this one, is usually congenital, which means you have a patent opening. For the scrotum, it usually descends down, okay? And this one is usually acquired, direct one. The path is that the hernia travels from the deep ring through the canal to the superficial ring. You see how this is so long? The hernia started off here, but it kept moving through the inguinal canal and it's now here in the superficial inguinal canal. Okay? And the direct inguinal ring is going to pass through the Hasselbalch triangle. I'm going to show you the Hasselbalch triangle right now. And then the relation of the indirect inguinal hernia is that it's going to be lateral to inferior epigastric. Why? Because that is where we said is the opening of the deep inguinal ring. The indirect inguinal hernia is going to start in the deep inguinal ring, and then it's going to move until the superficial ring. And then what's in the direct inguinal hernia? What are the arteries at risk? You have the medial to inferior epigastric, not the lateral ones. It's going to be more medial, that's going to be direct. If it's more lateral, it's going to be indirect. Now, with hernias, indirect, this is a repeated question in a lot of the every exam, you're going to have a question about indirect hernia. They're going to give you a case, a very long case, and they're going to tell you to guess whether this is indirect or direct. How are you going to do this? Look for two words. Look for the scrotum descent and look for the age of the patient. Every case situation or every MCQ they give about hernias is going to start with the age. Okay? But 95% of the time, they're going to give you an old patient. Sorry, they're going to, oh, this is a typo, guys. I'm going to have to change this. But this is going to be a young patient. Let me just scribble over that right now. Okay? If the patient is young, as in a toddler or young, like 4 or 5 years old, and the hernia has descended in their scrotum, it's an indirect inguinal hernia. If the age of the patient is more, let's say he's 70 to 80, it's an indirect hernia. That's a direct hernia, sorry. That's a trick that everyone uses everywhere. Okay? So if it's a young patient, indirect. If it's an old patient, direct. Now, we're going to go back to this one. This is the Hasselbalch triangle. This is where the direct hernia comes from because this is more medial. Okay? Now, this is the Hasselbalch triangle with the layer. But if you open the Hasselbalch triangle, this is what you would see. So, medially, the border of the Hasselbalch triangle is formed by the rectus abdominis. Okay? Laterally, it's formed by the inferior epigastric vessels. Okay? And inferiorly, it's by the inguinal ligament. So this medial is the rectus abdominis, lateral and inferior. Oh, I can draw it right now. Medial, lateral, inferior. That's how it works. Okay? Um, Again, inguinal ligament is nothing but the external oblique, guys. I really need to remember that. This is the slide I was telling you guys. Transversalis fascia is the first structure to cross any hernia, femoral hernia, inguinal hernia, any hernia. It's going to be transversalis fascia. Okay? Again, once more, I'm just reiterating. I'll make that correction right now. I'm really sorry for the error. Indirect hernias are going to be always descended, not always descend to the scrotum, but it's gonna be in a young patient. Okay, indirect hernias cannot be in an older patient. The reason of an indirect hernia is congenital. It's not usually congenital. It is congenital. Okay, and the reason for a direct hernia is acquired. But you have to be old to live a life to go through this. You know what I mean? Okay, which among these is a direct hernia and which among these is an indirect hernia? Yalla, 3, 2, 1. Let's say you answered. This is the hernia. Okay, and this is the hernia. As you can see, this is the one which is passing through the deep inguinal ring into the superficial inguinal ring. So this is going to be the indirect inguinal hernia because it's passing through the deep ring, through the canal to the superficial ring. So this is A is going to be the indirect inguinal hernia. Indirect inguinal hernia is going to pass through the canal, and direct inguinal hernia is going to not pass through the canal, it's going to be here. Okay? Femoral hernia, this is all low yield. I'm just going to run over it really quickly. It's below the inguinal ligament. The other hernias were part of the inguinal ligament. The inguinal ligament in the indirect hernia, as a matter of fact, was a part of the canal. Inguinal canal's lower border is the inguinal ligament. For common in females, complication is strangulation of the arteries over here. The neck is also narrow, and it's usually here. It's below the inguinal ligament. So for femoral hernia, I want you to remember that it's below the inguinal ligament. And it's common in female. That's all you need to know. These are the other hernias which were mentioned in your um slides. However, here's the thing. They've never brought these before. What I do think you should do is, however, remember the umbilical one. But the thing with the umbilical one is that it's very straight up. If it's near the umbilical scar, it's going to be the umbilical hernia. The periumbilical is going to be near the linea alba, near the umbilicus, not the umbilical scar itself. This is going to be from the umbilicus itself. So from your belly button, you're going to have a hernia. That's the umbilical hernia. Epigastric is going to be between the xiphoid and the umbilicus, which is going to be way up high. And then you have the spigelian or the linea semilaris or the lateral rectus sheath. Wait, I think I had added a picture of, did I or did I not? Okay, I probably did not. But okay, this is the perfect picture. But if this is up, if you would see it here, somewhere near the xiphoid process and stuff, that would be this one. I don't know how to, okay, epigastric one. The spigelian one would be here on the lateral border of the rectus sheath. Okay? And the periumbilical one is just near the umbilicus. And the umbilical one would be on the umbilical scar like this one. This is an umbilical hernia. Okay? This would be a femoral hernia because this is below the inguinal ligament. That is pretty much it. Again, do you understand, you guys? You are in the process of preparing a direct inguinal hernia. Which of the following anatomical relations will you find during the surgery? Direct inguinal hernia happens in, okay, 3, 2, 1. Okay, the direct inguinal hernia is going to happen in older patients. It is not congenital, it is direct or acquired, all right? So, is it going to pass through the inguinal ring? No, it's not going to pass through the inguinal ring. It's going to pass through the Hasselbalch triangle. What did we say are the borders of the Hasselbalch triangle? We said the medial border is the rectus abdominis muscle, the inferior border is the inguinal ligament, and the lateral border is the epigastric. You might think the answer is not the inferior epigastric because we said, Humaira, are you stupid? You just said that the Hasselbalch triangle's lateral border is the epigastric vessels. However, think about it this way, guys. The hernia is going to be here, but the hernia is going to be medial to the lateral, to the inferior epigastric vessels. But that's right, the hernia will lie medial to the inferior epigastric vessels. That is it. Here are the special cram sheets. This is Leen's. This is Leen's. This is Leen's. This is mine. This is mine. Thank you so much. We hope you enjoyed our pal. If you like us, if you liked our pal, please make sure to give us honest feedback. And if you really, really like our pal, you can give Leen a Mountain Dew and me a Kinza Cola. How do I